Hello, welcome again to Miami Community Health. I am Dr. Anthony Gonzalez, your host of Miami Community Health and Live Longer with Dr. Anthony Gonzalez. We are here to talk about a childhood disease, a childhood cancer that is not very common. Thank God it's rare, but when it does occur, it's quite serious. And I think it's important to bring awareness to this disease and this condition. So I brought with us today an orthopedic oncologist. This is an orthopedic surgeon that deals with cancer. When you think of orthopedic surgery, you think of broken bones, and you think people, a knee injury, a shoulder injury, something like that. But, there's cancers that occur of the bone and of the soft tissues around the bone that we need orthopedic surgeons to deal with. So I brought a specialist from Nicklaus Children's, T.J. Utset. Right, T.J.?
Yes.
All right. Well, welcome. So T.J. is an orthopedic oncologist. I explained a little bit about orthopedic oncology, but tell us a little bit more of what these type of docs and what you guys do.
Well, that cancer component is definitely a part of it, but orthopedic oncologists, we treat tumors of the bones and the other connective tissues as well. Some of those are benign, but some of them are cancers. Cancers of the bone, cancers of the muscle, cancers of the fat, and these other connective tissues. We're also a bit involved in some non-neoplastic, non-tumor, complex surgical issues that people have that require larger, complex or customized surgical solutions as well. But for the most part, we're dealing with tumors of the bone and connective tissues.
And you only deal with kids?
I only deal with kids, and that's a focus that I'm very happy to have been able to do here at Nicklaus Children's. There's a very small handful of us around the country at this point who are focused on pediatric orthopedic oncology.
Wow. Yeah, great. So what are the common tumors that you guys deal with?
Well, I would say when you say common, they can be surprisingly common. And I don't mean to scare parents out there. I'm a parent. I know from watching the show, you're a parent too. But up to 35% of kids will have some bone tumor or lesion. And that doesn't mean it's cancer. In fact, most of the time it's not. Most of the time it's benign. Okay. Things like a non-ossifying fibroma or bone cysts. There's multiple types of bone cysts, osteochondromas. And so most of the time, those lesions, those x-ray findings are benign, non-cancerous. They're discovered accidentally, incidentally. Kid falls down, gets an x-ray, and then, there happens to be this, and it's not what's causing them the pain. It has nothing to do with that, but that's where we pick them up. And a lot of times they don't need any surgery or treatment. Now, sometimes they do, because these things can weaken the bone. So even though they're benign and they're not cancer, they can weaken the bone. Bones can even break through them sometimes. So sometimes we do have to do some things to give the bone some extra strength to get that out of there, to protect the bone from breaking. And then we do treat the cancers as well. And the most common bone cancers, so malignant tumors in children, are osteosarcoma, that's the most common, and Ewing sarcoma.
Okay, so those are the two most common. Obviously, thank God they're not very common, right? I understand. I read something that a couple thousand kids a year will get these in the U.S. It's very small numbers, thank God.
Correct. Yeah.
Okay.
Around a couple thousand for sort of all those. There's about 9,000 to 10,000 pediatric bone cancers that are diagnosed each year in the U.S.
Oh, okay.
Anywhere between 3 and 6% of those are these bone cancers. About 1,000 to 2,000.
All right, so people listening to us, they're going to want to know, how do I know if my kid has a bone cancer? What do I have to be looking for? What are some signs, or how are they diagnosed? Is it, I remember from my schooling, sometimes, sarcomas, people hit their leg on the door of a car, they have a bump, they have pain, and, oh, doc, this mass came out from hitting my leg. No, that's not it. You just brought attention. Is this what happens with kids as well? How do parents diagnose this or know that something's wrong with their kid?
That often is how we find these things. And it's not for every parent to, anytime a kid bumps their knee or has a little bit of pain, in their knee or their arm, to jump to thinking these things, because they are quite rare. But that is how they're found sometimes. I'm a big fan of the show, and you've had some great docs on here, your colorectal surgeons, and they've talked about screening for cancers, and you see a lot of that in adult cancer, and there's a role for that, because often those have been you had I think a gyne oncologist on the show for cervical cancer too. These are slow developing things that have some abnormalities, and we kind of know when to expect them. We have high risk categories, and people get screened, but this isn't something that we can screen children for. These are much rarer cancers, and often they present with the sort of insidious pain that's just started showing up. Often parents will say, we noticed that it was swollen. And it's not necessarily that it's swollen, but it's that leg or arm is a bit larger because of the tumor, and it's often painful to the children. But like you said, sometimes people will have a fall and get an x-ray, or they'll sort of anchor it. Oh, it just started, but really that's just what maybe called attention to it.
So if you notice any swelling, pain, or a lump, is that what it is? And what parts of the body does this occur?
It can happen pretty much anywhere. Now, the most common site for osteosarcoma in particular is around the knee. Okay, it can happen around the shoulder. It can happen, even in the spine and some rarer places. Those are some of the things to look for. It's painful. These masses that develop, tumor-related pain tends to be a more constant type, not related to activity, and they can weaken the bone at times, and that can cause its own kind of pain. And then there's sort of classic cancer things that they're not always present, but unexplained weight loss in a child, some other symptoms, shortness of breath, things like that a child starts developing.
Okay, so the parent has a concern. They see a swollen knee. They see some lump. They go to their pediatrician, I would imagine. First, what is the pediatrician supposed to get there? An x-ray?
Yeah, that's usually the first step is an x-ray. And, as simple as x-rays are, and they've been around for a long time, those are still incredibly helpful in picking up some of these benign and malignant tumors, and we can tell a lot from them, and that sort of starts off the process, and then it's a bit of a journey. So they'll usually then be referred to orthopedics, pediatric orthopedics. So we have the Orthopedic Sports Medicine and Spine Institute, or directly then to Orthopedic Oncology. Now we have Pediatric Orthopedic Oncology for these sort of abnormal x-ray findings. And when we have a heads up on these sometimes as well, where we're a little more concerned, a little more suspicious, we accelerate that process of getting the additional studies that we need, like an MRI.
Okay.
MRI can
that
tell
would be
us
the
a
next
lot.
step.
That would be the next step. And at that point, I'm typically involved. Our medical oncologists are sort of involved. We've given a heads up to the pathologist as well, and the radiologist. It's a really sort of team effort, even the diagnoses of these, definitely the treatment, but even diagnoses of these tumors. And we arrange for that MRI, and then the next step after that is to get a final diagnosis, and that's done with a biopsy. So small procedures to get a sample of that. This is particularly if we're concerned that it's something malignant. Now, sometimes it's a sort of slam dunk, benign appearing, no aggressive features, and we can see how that does over time on x-rays, MRI, or both. But if we're concerned, we'll arrange for a biopsy. And that way we can look at it under the microscope along with the pathologists and get to that final diagnosis, run a whole number of other specialized tests on it too, looking at the genetics and next generation sequencing even on a lot of these, so we can better understand the tumor, better understand what the best treatments are going to be.
Now, you made a comment about a medical oncologist, and I want to clarify for our audience. A multidisciplinary team, you have the orthopedic oncologist, you have a medical oncologist, you have a radiation oncologist. So tell our listeners, what are all these types of peoples? Because I thought you are the only one that's taking care of this bone cancer for my kid.
Well, I'm glad that I'm not, and for a number of reasons. Obviously, it's very multimodal care. It takes that whole village, it takes that whole team, and especially at a place like Nicklaus, I love working with that team, and we work together every day. So it's a lot of us, and families end up end up meeting a lot of people and being involved in a lot. For the two main types of bone cancer, the kind of standard template of treatment is chemotherapy, followed by a surgery, and we call that local control, to remove the cancer, and then some more chemotherapy on the back end, the adjuvant chemotherapy. And so, a lot of the interactions directly, the kind of day-to-day, is with the orthopedic or the pediatric orthopedic oncologist, and then the pediatric oncologist. And they're guiding a lot of the show and looking for disease elsewhere in the body, because these cancers can spread. They like to spread to the lungs typically. And so they're looking at the whole body over time, and they're directing that chemotherapy and the treatment and the side effects that go along with it. These are very powerful medications, and they can be effective towards cancer, but there can be a lot of collateral damage to that too, and they watch and take care of those children through that whole part of the process together, and we're working together the whole time. But that's just the beginning of that team. The pathologists are involved as well. And although they're not necessarily, patient-facing they're involved from very, very early on. And we're getting a series of tests. And we're also, me and the medical oncologist, in contact with them pretty much every day for those first few weeks of diagnosis, to see as these results trickle in from special tests that take different amounts of time. There is a role of radiation oncology too, and it changes diagnosis and case to case, but for some of these sarcomas in particular, that is the better local control option, or something that we use in addition to that. And so we work very closely with the radiation oncologists as well as pediatric surgeons, pediatric general surgeons. And they help us, like I said, these will go to the lungs, and that's a big, part of it, and getting the ports placed for the chemotherapy. We're taking care of the whole child, and this cancer affects the whole body. And so we're often working together there. And, you wouldn't think it, but plastic surgery too is a huge part of it.
Part of the reconstruction.
Part of the reconstruction, part of the nerve reconstruction coverage, et cetera. And and that's really just the tip of the iceberg, I guess, in this we have interventional radiologists as well. They help us out with, and musculoskeletal radiologists, and getting to that diagnosis imaging-wise, helping us plan the surgeries, guide, understand that, and getting those biopsies a lot of the time as well in a minimally invasive fashion. So it's a huge
Wow.
team. It's a huge team effort.
It's a lot more than just you.
Yes, it's a lot more. I'm just a small part of it, and very excited to be a part of that team.
All right, so my kid has a cancer in the knee area. Does he need an amputation? Is he going to lose his leg? What's going to happen? I mean, we're talking about a kid. Typical age of these kids are how old?
It ranges, but we're looking sort of young kids, 8 or so, to teenagers.
Wow, so my 8, 10, 12-year-old kid, God forbid. Yeah. What is the surgery like? What is the aftermath like of these type of cancers?
Well, it used to be, and I mean, not even that long ago, amputation, like you said. And there's been a lot of advancement and a lot of innovation in the surgical treatment of these as well, in particular in what we call limb salvage or limb sparing surgery. So although in, coming up to the 1980s, most of the time these were amputations, and often for like even that knee, a high level amputation of the leg. Nowadays, about 90% of these osteosarcomas we can treat with some limb salvage or limb sparing surgery.
Wow.
And, but the number one goal is the sort of the oncologic goal to remove all the cancer.
Cure is number one goal.
And we're taking out we're taking out the whole tumor and the part of the bone where the tumor is. And we do have to take a certain amount of normal tissue around it. That's that margin, because, there are little cells that can be in that margin, microscopic. You can't see them without the microscope, and we don't want to leave any of it. Not a single cell do we want to leave behind. And so, that does make it challenging a lot of times to do these, limb sparing and limb salvage surgeries. But we would take, that whole portion of the bone, and then there's a number of options to reconstruct it. And there's a lot of unique challenges to that reconstruction when you're dealing with children. I think that's why this is sort of a growing
They got to
niche.
grow.
They've got to grow. So I brought some.
Yeah, definitely. Show us what you brought.
You know, because patients are often surprised. So, you know, we take out the whole piece of bone that has the tumor, that's the disease, let's say in a limb sparing surgery. And so we have multiple options to reconstruct it, and each kid is different, each case is different for what their tumor is and their goals, their function, their age. But one of the options is to replace it with metal. Okay, and so this is for the top of your femur, top of your thigh bone. This is a proximal femoral replacement. So this is one example of one of these implants that all of this area of bone would be replaced with this, you know, metal replacement for the bone, and then this goes, you know, forms the hip joint and moves around there. And we have ways of trying to reattach the muscles and the rest of the soft tissues to then maximize function as well. Like you said, kids grow, so that's, you know, this alone doesn't grow, but that's one of the great innovations that's really taking off now. It's advancing every year, is prostheses, these implants that will actually grow over time. And we've had some iterations of that for a while. They would require little surgeries to go and make it longer.
Right.
But we live in an incredible time now and rapidly progressing. We have ways of doing this non-invasively now.
Wow.
And, yeah, that's something we do a lot of.
So as the normal leg is getting longer, the
Correct.
affected leg, you're making it longer.
Correct. We can make this implant grow non-invasively without a surgery. You know, in the case of one of these, for instance, the kid we have a, you know, it looks like kind of a donut, like a tiny little miniature CT scanner almost, a little plastic thing with a hole that they can put their leg in. They don't feel anything. It spins a large electromagnet, and there's a gearbox inside of that, and it makes it just a little bit longer. They come back, we make them a little bit longer. And so as their bone grows on the other side, we can make this bone where we've replaced the
awesome.
joint and the growth center, the growth plate of the bone, we can make it longer. So that's one option, you know, with metal, because we're often having to take the whole joint, and that's where that growth center is. But sometimes we can even leave their growth centers. If the tumor's in the middle of the bone, we can do that. And we take out that segment of bone, leave their growth centers, and we can put in a bone from a cadaver, sometimes even one of the child's other bones from another place, like a fibula. And that leaves those growth centers intact, and then they can natively grow. And that's another room, you know, place where we have a lot of innovation. I should have one more prop here, because this is something that we work on a lot now in Nicklaus with, you know, the 3D lab and our new partnership with Rico and with Insight Surgical to make custom 3D printed cutting guides that allow us to take just the right amount of bone in a shape that's going to help us improve healing, improve function, and match it to that donor bone, so that when it comes in, the whole reconstruction's pre-planned. We know everything's going to fit great, and we get that. We do all
So
the
what are
planning on
we
the
seeing
front
there?
end.
That's the tumor there? The red is the tumor?
Yeah, this is an example, a sort of smaller scale of that. Instead of taking out, you know, the middle portion of the bone, like, you know, sometimes here we would take out this whole middle portion of the bone and can replace it. But in this case, there's a tumor that's red here. This is the bottom of the thigh. This is the top of the thigh bone. This is the bottom of the thigh bone by the knee. And here there's a tumor growing off to the back of it. And, you know, this might be, if I had to, this is a demo, this is an actual patient, but this is sort of the growth pattern of a type of osteosarcoma called the paraosteosteosarcoma, where it's a little less aggressive, and we don't have to be necessarily as aggressive in getting rid of the whole joint. But doing that freehand is very, very difficult. And so this guide would allow us to cut out a good margin around that bone and to then match that up with a cadaver bone that would plug back in there.
Wow.
And reconstruct the bone. And so if we can do those biologic reconstructions, you know, that can help with function as well. So we've got sort of a number of options in that way. And the last thing I'll say is, you know, parents are, and understandably, really afraid of amputation. Is that we've really cut down how often we have to do that. But sometimes that is the best treatment and the safest treatment to achieve that cure, the number one goal. And so we've done a lot of work too, and this is where that multidisciplinary team comes into play as well, to improve outcomes in amputation. We do, and this is one of our partnerships with Aaron Berger, our plastic surgeon there specializes in nerves and this microsurgery. We do, when we do these amputations, we do targeted muscle reinnervation, where the nerves that get cut at the time of amputation are reconnected, so they have something to do, and that lowers the rates of phantom limb pain. The upper extremity, that can set us up for these bionic kind of prostheses and new technology. And we can even do things, you know, where you might think, well, we have to do an above knee amputation, an amputation through the thigh. It takes a lot more energy to walk that way.
Right.
We can do a surgery called rotationplasty, where we take the ankle and we turn it into the knee. And you turn an above knee amputation into a below knee amputation.
Wow.
And, you know, there's kids with these that can dance, do sports, you know, run, and
that's what I wanted to know. So what happens, you know, let's talk about the success stories. You know, these kids go through these multidisciplinary care. They have surgery, they have chemo before, after. Talk to me what happens with these kids 5, 10, 20 years later in adulthood. You know, we want to cure, we obtain the cure. Now, what about their life? What about their functional ability, their psychological well-being? What happens?
That's a big part of cancer care, and that's a huge part of pediatric cancer care. And that's a whole, you know, I mentioned we just talked about the tip of the iceberg of that sort of support network and the team and the multidisciplinary team. And that's a whole other part of it that's so important. Because at the time of treatment, these children are going through, there's a lot of adjustment, there's a lot to go through. And we have psychologists and psychiatrists and child life specialists. This is one of the advantages of being at a children's hospital for your treatment, is that we have a lot of those. And there's a lot in this sort of field of then survivorship and life beyond cancer, life after cancer. You know, fertility can be affected, and that's something that we try to secure and set up options for on the front end before initiating therapy. And then with a lot of these surgeries, because a lot of these bone and soft tissue, you know, sarcomas are the cancers of the bone and the other connective tissues. They're often in the extremities. And that's where we get, you know, sort of a lot of our movement and function from. And so, you know, over time, we do have to sort of sometimes tweak these, address these as their needs grow, as that patient grows. So there's a functional component. Throughout the process, we work really closely with physical therapists as well for the physical recovery. And then there's obviously the mental recovery from these two. So it takes a village, and it's an ongoing thing. And I think one of the beautiful things of orthopedic oncology, one of the things that drew me into the field and honestly sort of drove me to then further specializing on the pediatric side of it, is that it is a long-term, it's a long-term process. And you get to watch these kids grow. You get to be a part of their battle. You get to be a part of their lives. You get to be a part of that fight against cancer and the life after cancer, right? And you know, those needs they evolve over time, and we address them as they come up.
That's awesome. That's awesome. And we wouldn't be able to make all these advancements without research. So clinical trials, and we've had other people here talking about clinical trials and research and involvement. Is that available at Nicklaus Children's? And talk to us about that. And, you know, I'm sure others have had to enroll their children in clinical trials so that you could be able to accomplish what you're doing for these kids today. Yeah. What's the importance of clinical trials?
Super important, not just for that individual patient, but as you alluded to, the other kids, the kids in the future who are going to get this. And the Helen and Jacob Shaham Cancer and Blood Disorders Institute at Nicklaus Children's is actively involved in research. We're a site for multiple children's oncology group clinical trials, other cutting-edge clinical trials, and, you know, very specific to us. And this is a really exciting, just sort of an example, just one example that I've been involved in recently and learning a lot. And it's just been really incredible to see the work of Dr. Maggie Fader, who's the director of our sarcoma and solid tumor program at the Shaham Cancer Institute, as well as a team over at FIU, is the ex vivo trial. It's just one example of a clinical trial that's bringing precision medicine, precision oncology to children on unprecedented sort of scale, that we can do this, where, you know, we have these kind of protocols and chemotherapy agents, and we know that work, and these clinical trials help us discover new ones, adjust the doses, and get better, make things better. But each child and each tumor is different. And with this ex vivo trial, the work they're doing is really incredible because they can look at an individual child's tumor and test it against over 100 different chemotherapy agents, the way you would the sensitivities of a
bacteria.
Right. That's a very oversimplification, but for a bone doctor, that's how I internalize it.
It's a simple analogy.
And it's pretty neat. And then they can really change treatment, change therapy. So that's just one example, but all these clinical trials and that research advances the treatment. And I'll say with osteosarcoma, the survival of osteosarcoma used to be 20% at 5 years. And, it was because of research and because of these advancements in oncology that in the 70s it jumped up to about 60%. And that was with the introduction of chemotherapy. Now, it stayed about the same, though, since the 70s. So that sort of treatment paradigm, we've made a lot of innovations in sort of surgically and limb salvage and sort of multiple points along the way. We've tailored this chemotherapy. At Nicklaus and the Sham Cancer Institute, they're able to do a lot of this that used to have to be inpatient in the hospital. They can do out. So there's been advancements there, but the survival has sort of hovered the same. And that, to me, just highlights, the role of research and discovering new therapies, because that's what's going to help us.
We need to push it further.
Push it further, exactly.
Right. Wow. Okay. So we've learned about these childhood orthopedic cancers, soft tissue cancers, the osteosarcomas, the Ewing tumors. We've educated our parents that they have to look for signs, swelling in the knee, masses. Start with your pediatrician, get an x-ray, and then God forbid, you have something, you'll be cared for by this multidisciplinary team at Nicklaus Children's. There is hope. There's good treatment. There's good cure rates, and there's good limb salvage rates. All right. So we've learned about that. But obviously, a lot of this also has to do with your interest in innovation. And I wanted to spend the last few minutes to talk about your interest in innovation and what's happening in innovation that you could tell us in these areas or other areas that is exciting for you now and possibly in the future.
Yeah, well, it's a really exciting time for surgical innovation, I think, across all specialties. And I've been lucky to see a lot of that develop in orthopedic oncology, but you're sort of seeing it across the board with the explosion of technology and how we can do that. Some of these things that I showed you in terms of patient-specific, custom, rapid prototype, things that used to make custom implant stuff take weeks, we can speed up that process. We can 3D print metals, we can 3D print plastics. We can I'll show you a couple, other examples here. If you're planning a surgery for a tumor, that you can view it, hold it in your hands, and plan that surgery physically with a 3D printed model or virtually. And that's where augmented reality, which is, having an increasing role, and we're experimenting with that too in the operating room. One thing's virtual reality, and that can help us on the back end in planning these surgeries so that we're doing most of the work before the surgery and everything's ready to go. Same with the 3D printing and testing and virtual planning. But then to take that one step further during the surgery and be able to have overlaid in 3 dimensions.
Wow.
And so, that's just a couple examples kind of on the 3D space. But there's navigation as well. You see that across various surgical specialties now, and that's another way of tying in this 3D information and even augmented reality, sort of with see-through glasses that can overlay the imaging. And we and you may have heard, we have the new Ken Griffin Surgical Tower. It's sort of, it is state of the art, probably the most technologically advanced pediatric surgical tower dedicated to surgeries, large operating rooms that have built in the ability to use these new technologies and sort of the space and infrastructure as we keep advancing.
Wow.
Whether it's AR, VR, 3D printing, virtual planning.
That's awesome. It's awesome that we're seeing this for our kids, for our community. So I want to thank you. Thank you for what you do. Thank you for caring for the kids, and thank you for caring for our community. And it's very inspirational to see that we have this type of specialty within Nicklaus Children's in our community. Thank God my kids are grown. They're not kids anymore. So yeah, obviously we won't visit Nicklaus Children's, but I know a lot of us in our community, that is the go-to place. And we at Baptist Health obviously now have pushed all of the kids over to Nicklaus Children's as well. So we don't do really any kid care at Baptist Health. So you guys have been the premier here in South Florida. So on behalf of myself and our show, Miami Community Health, thank you. Thank you for what you do, and thank you for what you do in our community.
Yeah, thank you so much. It's an honor to be back home taking care of the kids of South Florida at Nicklaus, and a real honor to be on the show. I appreciate it. Big fan of the show.
Well, obviously, Dr. Anthony Gonzalez here with Miami Community Health and Live Longer with Dr. Anthony Gonzalez. Another educational topic, learning about our kids and this unfortunate cancer that can occur. If there is a concern, see the pediatrician. See a specialist at Nicklaus Children's, like Dr. Utset, and there is hope. There is hope. As